everybody. My name is Cindy Brown. I'm the founder and co-administrator of the Autonomic Dysfunction Dysautonomia Facebook support group. We're very pleased to have you, and we want to start out. I'd like to introduce my co-administrator, Morgan Hart. Hi, Morgan.
Hi.
Morgan has been with me from the beginning, and she helps with all of these events that we do and advises us on we have questions, and we're just very, very pleased to have her. So Morgan, go ahead and start with the disclaimer.
All right. So by participating or listening to this content, you agree not to use the information presented here as medical advice in treating any medical condition. This forum does not constitute a provider-patient relationship. The content here is for informational and educational purposes only. Because each person is so unique, please consult your healthcare professional for any medical questions or treatment options.
Thank you. Thank you, Morgan. While we're during the participation, the presentation, if you do have questions, please put those questions in the chat. Morgan will be going through and capturing all of the questions, and Dr. Frye has been kind enough to agree to answer questions at the end. So don't hesitate to put your questions in the chat box. So Morgan, back to you.
Okay, so I'm going to introduce Dr. Frye. Dr. Frye is a pediatric psychologist in the chronic pain clinic at Johns Hopkins All Children's Hospital. He specializes in non-pharmacological treatment for patients with acute or chronic pain conditions and provides skill-based interventions for simultaneous psychosocial concerns. He joined the hospital staff in 2018. Dr. Frye earned his doctoral degree in clinical psychology from Auburn University. He completed a pre-doctoral internship in pediatric psychology at Children's Mercy Hospitals and clinics, and a postdoctoral fellowship in chronic pain at Nationwide Children's Hospital. Dr. Frye's research interests include pain coping and catastrophizing and parental impact on youth outcomes. He's board certified in biofeedback by the Association for Applied Psychophysiology and Biofeedback. So thank you, Dr. Frye, for being here.
Yeah, and thanks for having me. I probably should have updated that a little bit because I also work in our autonomic dysfunction clinic, and dysautonomias are one of my research interests now. It's one of my main areas. But without further ado, I'm going to share my screen. Give me 1 second for that.
Thank you.
We can get this started from the beginning. All right, there we go. There's the slide. Well, first, I'm glad you're all here. I know it's a Saturday, and taking some time out to learn a little bit more about dysautonomia is a good thing. I'm glad that you're part of it. And what I want to do with this is address some of the concerns that are often seen with those with dysautonomia, whether it be adolescent and adult, and really problems that transpire across the journey you might have. When we started this, actually, I was talking to Cindy, and we were trying to think of what's going to be something that's really going to be meaningful to this group. And so this navigating life became more of this broad topic we wanted to hit. And specifically, there were a few different things that came up. She actually made a poll, which I'm sure some of you responded to, about the content people wanted to know. And so the content, I'm going to talk about all these areas, is really focused about the things that people struggle with, the things that can be challenging. And my hope is that everybody that's part of this, that we're going to be able to hit some of the things that relate to you. It might not be specific to you, and I don't think I'm going to get to everybody's specific concerns, just because this can be so broad and everybody presents a little bit different. Your lives are going to be different. But I'm hoping there's some takeaways that you can take from this and can move forward with. So what I'll do is I'll talk a little bit about each of these areas. I'm going to give a little bit of research behind it because this is some of the area I've delved into, but also hopefully some tips, again, more broad strokes about this, but might be helpful for you. And we are going to start with one that's quite problematic. In fact, this is one that comes up more often than not. And most people I've talked to at some point of their journey, they've had this, and that's disbelief. It can come from a variety of people. It can come from providers, can come from friends, can come from coworkers and family members. And so it can be a pretty difficult thing, especially when you're already struggling, there's already things going on, and then, of course, someone not believing this experience that's happening. Now, to talk about this and some of the areas I'm going to talk about as well, I'm going to use a lot of data that is qualitative. So it's data that comes from other people with dysautonomia or POTS specifically. And I'm going to use some real quotes from people. I'm actually going to use some of my research because this is the area I really care about, and I love some of the quotes, as well as another study. And I'm going to start off just showing you some of what we found over here. And again, this is not everybody's experience, but some of the major themes we found. This was a study in adolescence, but I want to tie this together. The themes, I'm not going to go in order. The one we started with is this negative impact. And so you're dealing with something that's very real. You're dealing with something that can impact life in all types of areas, which can have a big effect. We also, if you go down to theme 4, which out of order, but we say that POTS, POTS is a novel condition. We could use the word dysautonomia for this too. I don't think it's novel so much anymore. What I wish I could change this to is understudied, under-researched, not well understood condition, but something we need more resources. We need more understanding. We need providers to get that. And we'll talk about theme 3 some too, this whole need for trust and advocacy and people that support you. But the disbelief falls into this theme too. Now, this is, again, adolescents with POTS. That was my study. But we could say adults, adolescents, dysautonomia. You experience invalidation. That's part of this that comes up. It can come in all types of social situations. And of course, it's not a good feeling when it does. I have some quotes. These are from real people. These are real quotes. First one, this is from a mom. Both of these are from the same mom talking about her daughter and their experience. The daughter was experiencing a lot of some symptoms, as you might do as well, some that are very much the dizziness and the tachycardia and things that maybe a cardiologist or neurologist sees. But she was having a lot of GI concerns, which are pretty common in dysautonomia. So they send her to her specialist to get help, and that's what she wants is help. But here's hers. The GI specialist said, think healthy thoughts, and you'll be healthy. And what does that say to a type A kid who is successful at everything they do? You're not thinking healthy thoughts. That's why you're sick, and so this is all in your head, basically. And then later, same person would get in the car after one of those doctor's appointments at the specialist, and she'd just break down just in hysterics and just be crying and sobbing and saying, what's wrong with me? Why do they keep telling me there is nothing wrong with me? Now, unfortunately, this is probably something that a lot of you can relate to. You go to your provider, you want to get help, but they don't believe what you're seeing. In fact, there's disbelief, or it's all attributed that this is mental. This is something wrong with you mentally, which we know is not true. Science evidence would not back that up. Either as a psychologist, I can tell you that's not true. However, it's the invalidation that a lot of people get. A couple other ones. This is another person talking about medical providers again. You try to tell them, oh, I'm having this symptom. And what they say is, you aren't having that symptom, or that's not a symptom of POTS. They keep on telling me that you aren't having that symptom. Are you lying? And that's a bit annoying when you're having all these symptoms going on and they tell you you aren't. You know what you're feeling, but they don't believe you again. And a lot of this can come from a lack of understanding. Or another one similar. I just felt like my doctor had his mind set already. Like he just felt more like what I was saying was wrong. And that's what it felt like when I was talking to him. Like it wasn't like what I was telling him wasn't true. And I'm like, this is how I feel. So again, in both these situations, we have people that are saying, well, you shouldn't feel this way. This is not what the condition does. Instead, here's what you should be experiencing. And of course, you're the one that knows it the most. So what do we do with this disbelief? Again, you're probably going to experience it at some point. Unfortunately, it happens to most people with dysautonomia. If we had to give broader recommendations for this, education is the biggest one. A lot of the time, ignorance is our problem. People don't understand what dysautonomia is, or they have these preconceived notions about it, and therefore they don't treat people with the respect they deserve. They don't believe the symptoms. But like any manner that you'd want to show what you're thinking and believing and pass that to another person, it really comes from conversation and information. Those are the two big ones. Conversation being something calm, being something cordial, being something that's meant to help the other person. and providing them with information. This is whether we're talking about a provider, whether we're talking about your cousin or this caregiver or your sister-in-law, whoever it might be, giving them information, whether it be from a website or from a journal article, like a medical article, or even a YouTube video, something that describes a little bit more of what you're experiencing, or even in that conversation, just being able to describe what you're experiencing or what it's like to give them a better understanding. Not everybody is going to get it. That's the tough part in this. And a lot of you, I'm sure you've tried to explain it to people maybe once, twice, or more, and it doesn't always work. I do believe there's hope, though. And I don't share this with all the groups. I'll share it with y'all. I actually was one of these bad providers at one time. I hate admitting it, honestly. But when I was in my training, when I was in my postdoctoral fellowship, the medical doctor that I was training under, when I asked him about what is POTS, I actually didn't know the word dysautonomia back then, but what is POTS? His response was, oh, they're losers. These are these people that are kind of feeble and weak-minded, and that was how I was trained, which is a shame. And I think until I learned more about it, until I read more about it, and especially when I started seeing patients and them talking to me and explaining what they were experiencing and having these conversations, much more than, hey, I'm feeling bad today, or I'm having this symptom A and B, but more of here's how it's affecting my life. Here's what I want to be doing, but here's how it's stopping me. And really getting that personal connection. That's when I started to change. And now, I mean, I'm one of your biggest fans. I'm a huge advocate. This is what my research is about. It's what my clinical work's about. But I say that to note that with education, with information, people can change how they feel about this and start believing your experience more, which is what we want. Other thing for this, the advocacy, I mentioned it a couple slides ago, but being able to stand up, not just stand up for yourself, but really to be able to talk about what you're experiencing in a way that's that other people are going to understand, whether it be a medical provider, whether it be someone in your family, to have the information that you can share with them. I mentioned the word question, because with doctors, I think you should be able to question what they're doing. I don't want you to be mean about it, please, but to ask them, why is this the treatment? Or to ask them their conceptualization, especially if there's ways that they're making you feel like it's all in your head or something incorrect like that. The word fire is there because you do have the ability to fire your doctor. Now, depending on where you are, you may not have a lot of access. There might be only one person. In those cases, maybe not. But in others, I think this is important to have somebody that believes you, or at very least wants to learn from you and supports you. And we can keep on looking for those people. Every year, more and more of them show up. But lastly in this, you got to trust yourself. The experiences you're feeling, even if somebody says, well, this isn't how it should present, this must not be real, so therefore you're faking, well, you know what you feel. You know what you're experiencing. I have patients, I actually had one yesterday, who she came in and she'd had a very similar experience where a provider had told her, hey, this is not what you should be feeling. Sorry, my slides moved. They said, hey, this is not what you should be feeling. And therefore, she started to doubt herself. Well, maybe I am making this up, or maybe there is something wrong with me. But that's not the case. And part of the advocacy and part of gaining this education is to be able to say, hey, I know what I'm experiencing. These are real, and here's what I need help with. So my message from this is don't let others' lack of understanding get in your way. Now, when the polls went out, I guess that was a couple weeks ago or maybe longer, and they're asking about things that people were interested in, all of these words came up. I like to group them a little bit. My thought is all this change, this challenge that happens with dysautonomia, it affects us all a little bit differently. But we see that whether it be the loss of the abilities to do things, or the loss of people, which goes into that abandonment of I don't see them anymore, or they left me, they don't support me anymore. Then there's a lot of times this feeling of grief, that person I used to be before these symptoms happened, and wanting to go back there and be that person again, to be able to do those things, to live that life. Or maybe it's more future oriented, that I had these things I wanted to do. I had this potential. I could have been this. I should have been that. And these unfulfilled dreams. All of these are quite common, but also quite distressing parts of this journey that happen. I have some quotes with this, and hopefully they validate some of the experiences you've had, because these are, again, common. One person talking about their occupational career. It's hard because I've talked about going back to work, but at this point, who's going to hire me? When I go tell them I've got to miss this day and I've got to miss that day, someone who is talking about because of their symptoms, because of their appointments, how can I work? Another person talking about academics. I attempted to go to college. I was so stressed. I thought about doing something, a course online, but at the moment, with the symptoms that I have being so extreme, I'm hoping eventually in my life I can work and I can finish college, but for the time being, there's nothing. Again, these thoughts of what I want to do, but don't feel like I can, these unfulfilled dreams. Thinking more of this change in social as a mother talking about her teen, it's very isolating and people don't understand. I mean, teenagers do their best, but they're self-centered. That's what being a teenager is. So they don't see you every day at practice. You're out of their life for good. And she's lost a number of friends like that. Or this whole thought of out of sight, out of mind is one of the things that happens in teens for
I
this.
didn't hear you. What?
It happens with adults as well. Uh, Along with this, another person, this is an older adult. I've been living with all this for the last like over 10 years. I've lost a lot of friends along the way, of people that just don't want to deal with it, or like, or just always sick, whatever that looks like to them. People that feel like these symptoms you have, they're too challenging for me. I need to separate from it. You're too much, or at least the worry that that's there. Again, common. I can't say that enough. These are normal feelings, but at the same time, these emotions, while valid, they're tough. Then the situation can often seem bleak. It can seem hopeless, especially when the symptoms are getting the best of us. Now, you probably already know this, especially in the cases of abandonment of support. Building back support is vital in this. We have to do things that allow us to get support from others, to feel like we have connection or someone to get us through all this. I have psych help, whether that be psychology or psychiatry. Sometimes that's something that's helpful in this. Again, as a psychologist, I can say this is not a mental health condition. It is not in our book of mental health conditions. However, the impact that dysautonomia has on mental health is there for many, many people, and rightfully so, because of how much it can impact one's life. Now, if I'm thinking about what can we do with this, these thoughts of loss, abandonment, hopelessness, grief, what I think of is noticing yourself as you evolve, seeing yourself as a river that's ever changing, even if slowly or maybe big. Uh-oh, my screen stopped. I lost my connection. What? Sorry about that. Let's try this again. 1 second. Gotta love technology.
Yes,
Share
indeed.
screen.
The storm's
Share.
rolling in.
All right, are we back? Here we go. Woo. All right. So again, what we want to notice is this is something that is going to change you. You have something big in life happen, and this happens for all types of different ways in people's lives, whether it's death that happened, a big change, a move, or illness, especially in the case of these symptoms of dysautonomia that change us. And it's hard not to focus on this self that I used to have, this person that had more abilities, maybe, that was able to do more or didn't have to struggle through some of the days. But the goal is then, well, this has shaped us. We are now a different person. And the hard part is to not focus on that past, but now create that new vision of who I'm going to be. This is incredibly difficult. This whole new vision piece, looking about where do I get fulfillment? And if I can't do this thing I once did, well, what can I do? How do I change this vision? Which again, doesn't feel good. I use the word rebuilding. Rebuilding stinks. If we think about what that is by definition, rebuilding means I have built something, it's no more, and I have to build it back, which is frustrating. I think of the videos, I see them on YouTube and Instagram sometimes, where people build these really intricate structures out of Legos or dominoes or something else. And as they're working on it, somebody walks in and accidentally knocks the whole thing over, and it's so tough. But that analogy fits really well for this. Is I built everything up. I had this, this was this life I saw and envisioned, and it looked wonderful, and then it got knocked over. The tough part is then what do we do, and how do we put those blocks back together, knowing that we might not build that same structure? The goal is, or the thought is, maybe you can't, maybe that's not what's in the cards right now, and you can't build this huge elaborate thing you once dreamed of. But how do we build something else with those blocks? Because there's still something else that can be built with life that's still important, that's still of worth and still of value, and seeing how that looks for you. All right, let me shift over to caregivers. This came up too, the caregivers, because a lot of people, we have kids, especially kids with dysautonomia, or if you're a caregiver of an adult, it can be tough. There's a lot of challenges. The challenge that came up, at least in the conversation that was listed in the polls and the conversations we were having with this group, were concerns about mood, adjustment, specifically things about depression that come up, especially in teens and young adults. We can apply it to anybody, though. First, again, very common for any of you to be touched by this and have concerns with mood or just adjusting and dealing and coping. That makes sense. But for caregivers, and this is going to be a little bit shorter than the other ones, I usually fall back on a few things. First, as a caregiver, you got to trust your hunches. Parents usually know their kids the best. They know their kid, they've seen them grow up, and you can notice as changes happen. And kids don't always want to share or even accept when mood is getting affected, especially our teens and young adults. And so the first thing for a caregiver is to be able to trust that, to notice it, and then have that talk, whether it be with your child, whether it be with the provider, but something to say, hey, here's what I'm seeing. And again, it could be something that's a very gradual change. And you're like, wait a second, this isn't the same kid I had 4 or 5 months ago. Or maybe it's something bigger and more in your face, where there's this huge hit of depression or even suicidality, which isn't uncommon in this population, unfortunately. And so these are things we just have to look for. As a parent too, what do I do when my kid's struggling? Well, it's establishing support, and think of that broadly. It's support in the case of caregivers, or not caregivers, providers. So your medical providers, it could be support in the sense of psychology or some other mental health professional. Or maybe we're just talking about making sure they have other supports. Would it be friends? Would it be they need to be in a group somewhere where they can meet people? And then helping the kid help themselves. And again, this can apply to our adults too. How do we change stuff so they can still be functional? If they like going to the amusement park and they get, they're with their friends there and that's how they get support. Well, maybe they can't walk it, but maybe with an assistive device, they can do it. And, they like to hang out with their friends and go to the mall or go to the movies. Maybe they can't do that right now, but can we have friends over and do movies at home? Again, keeping them in sight, in mind with those peers. And again, for our adults with dysautonomia, that applies to you too. How do I start building this support back and having people that I can be around, talk to? The last one, monitoring changes. I kind of touched on that with your hunch, but just noticing as things change, good or bad, and being able to describe those, whether it be to a provider, to even talk with it. That change is something you have that's objective, that you could say, hey, I'm noticing this, I noticed that, and even can spark that conversation with a team, which can be helpful. Now, the other thing people were talking about is a coping tool belt. Coping skills, they're vast, they're broad. Everybody needs them, whether it be for dysautonomia, whether it be for mood or something else. We all cope a little bit different. I'm going to, again, paint some broad strokes to talk about some different ways to cope, but hopefully it sparks some ideas or things that you can try yourself. When we're thinking about coping, distraction is probably the easiest. You're all very good at it, I'm sure. You have your electronics, you have those things that are mindless that just take you away, which can be good when you're struggling with mood, when you're struggling with symptoms or other things like that. I know for some people, that could be the distractions. Doesn't have to be electronics. It could be like a coping thing. Some people have a coping list or a coping wheel or a coping box, something tangible they put stuff in or list out that they can do that's very much I can touch, I can feel, I can see. And for some people that works really well. Again, we want to create coping skills. But then there's hobbies too. I want to make this one somewhat broad because with hobbies, some people with dysautonomia, this hobby I enjoy doing, I can't do anymore. What my symptoms are affecting me, how they're affecting me, won't let me do this thing that's important to me that I cared about. So then it's how do we find new hobbies? Now, that can be tough because we often don't know what we like till we do it. And I would say there are resources. If you go onto Google right now and typed in, what can I do at home when I'm bored? Or what kind of hobbies can I do while sitting on my couch or laying in my bed, especially if we're not able to move around as much, there's probably lists and lists and lists. I know you'll get at least a dozen of different things you can try. And then of course, fitting it to what is important to you. And especially if that hobby represents something you value, represents something that's important to you, and makes you feel like there's some purpose, that's important. My thought is, I mean, symptoms can be very intense, they can be very impairing, and we still need to be doing something. May not be a big physical thing, but something to keep the mind engaged, even if the body's not cooperating. Now, the second piece, the coping skills. Think of it broadly again. We're talking about coping skills broadly. Let me focus then on psychology, especially. And we're thinking more of the cognitive coping skills. What do I do with these thoughts, these feelings? Actually, that whole slide earlier, the grief, the worries about the future, the past, these are things that we can address. Ideally, what we don't want people to get stuck in the past. We don't want you to be thinking about what could have been or what should have been or who I was and envying and grieving that person. Very normal, by the way. I expect it in most people. But we don't want to get stuck there because it's not helpful for what happens next. And similarly, we don't want to think about all that could have been and I want to do, but I can't, and beating ourselves up because our body's not allowing us to do these things, but rather focusing on where we are in the moment and what we can do, even if a seemingly small thing. And well, again, how do we slowly build it? Psychology can be great in giving that support. I recommend psychology to a lot, if not most of my patients, even patients I see in clinic. Obviously, I'm a psychologist. But it's not because I think anything is wrong with the person that you have dysautonomia and therefore you must see a psychologist, you crazy person. That's silly. Rather, it's because this affects you in a whole lot of ways. It can be very difficult to cope with. There's these real strong emotions and thought patterns that can get attached with a life where symptoms are really affecting us. And therefore, it's helpful to have an expert in some of these situations. Now, the word below it, ACT, you may know it. For my teens, this is usually a scary word because they think of the standardized testing. This is not that. Rather, ACT stands for acceptance and commitment therapies, which it's a type of psychology we use that really focuses on values. The word acceptance, some people get iffy on that. And the point of this therapy isn't that you need to accept it and deal with it. It's more of accepting where you are, or better yet, acknowledging the situation you're in. And then how do we commit, that's the C, to a value that's still important with us. And I like ACT because it's made for people who are struggling. It's made for people that are really stuck. And it doesn't matter the reason. It doesn't matter what's going on. What matters is how do we stop the struggle with this thing we've been struggling with and find a way to still live given the situation we're in. It's going to focus on values again, which I'll kind of repeat myself on this. When we're thinking function, when we're thinking hobbies, when we're thinking what can we do, we want to build on that value. So again, you have this life that's still important, that's still worthy, has worth, that's valuable because you're doing that thing that's important to you. I mentioned support. One way to get support, if we're thinking coping, is support groups. Which, hey, look at you. You're here. You're with this group. You're involved with it somehow. This is the type of thing. You have like-minded people. You have people that are going through similar struggles. And it's good to have those people around you. But I think of support in all types of ways. Maybe you just need somebody that empathizes with you and tries to understand. I don't know if most people are going to understand everything. Well, actually, no, no one, even the other people on this video, they're not going to understand your experience. You have specific things that have happened to you. Your story and the ways that you've been affected is going to be a little bit different. Uh-oh, I think I lost it again. Yep. Uh, Pardon me one more time. All right, we're back. I don't know what's going on with my computer. One more back. Okay. What I was saying though is people that can try to understand you, that can feel you. And it could be other ways too. People that advise you, people that mentor you, people that motivate you and help you do things. That's what we're looking for with support. And also just getting the right providers. Mentioned it before, can mention it a lot. Having people that want to understand, try to understand, are there for you or help you move in a way that's going to improve your life is super important. Lastly on here, coping skills, relaxation and calming stuff. There's a little bit of emerging evidence that shows that some of the relaxation skills, pace, slow breathing, especially from your diaphragm, progressive muscle relaxation, this tensing and relaxing, mindfulness or mindful meditation, all of those help the autonomic nervous system. And there's a lot of ways that the autonomic nervous system becomes affected, but at very worst, these type of skills are physiologically beneficial, but also are just good for if we're struggling, if we need to calm ourselves down, if we have comorbid anxiety or other problems going on, they're just good coping skills to have. No way that this is an exhaustive list. There's plenty of other things, but the important part to note is we need some type of toolbox. We need to have some go-tos that we can do. This journey's tough. All right, I'll start pulling it together. Functioning. This is a very important piece. And when I think of functioning, it's all about what's important to you. You may not be able to do everything you dreamed of. And there's plenty of reasons that happens to people with any type of life. But let's think of you. These symptoms may have gotten in your way. They may have stopped you from doing this and what I planned out. But how can we still live a life in line with the things that are important to you? Or why were those things important to me in the first place? And are there still things I can do that are consistent with that? Um, it's tough because we're in 2024 and there's still a lot of limits. There's limits in understanding what you're going through in dysautonomia. There's limits in the services there, and some of the stuff you have to do to live that life and function is self-led. And that's tough too, especially when we're already talking about symptoms that can be quite impairing. My thought is, though, is just doing a little bit more, small incremental steps. Could be with activity, you can see the list, school, work, friends, hobbies, whatever it is. But picking the thing that's important to you that works with what you're experiencing. Not everybody is going to be able to get up and do all these big activities, and that's not necessarily the goal. But doing a little bit more of the things that bring you joy, that bring you fulfillment. Also follow the recommendations of your doctors, but hopefully those are in line with those. And last is just having structure and routine with this. You're going to have bad days. You're going to have days where things flare up. You're going to have days where you thought it was going to be good and something unexpected comes up. You're going to have days where you are motivated and you do stuff, and then the next you're like, oh, wow, I overdid it. That's common. But the more we can stay consistent, the more we can build a routine, and especially live in one that's in line with who I want to be or what's this life that I want to have, given what I'm working with. That's what we're going for. And I think that's what really helps with some of these more difficult thoughts about how it's impacted us. Again, this is tough. For that structure and routine, you might need somebody to motivate you, especially on those tough days when the symptoms do rock you. You're going to need that support again to do this. So let me bring this together. All these emotions, isolation, validation, grief, sadness, and many more are very common and valid experiences that many people with dysautonomia experience. None of that makes you crazy. None of that is necessarily a problem in the sense of it should be there, but they are things that we can address, and I hope you do. Next, the symptoms of dysautonomia. They can be life-changing, and probably many of you have experienced that, where things that I once thought didn't happen, these plans I had to change, and I've really had to shift and adapt. And again, a common thing. This is a very impairing and real condition. And because of that, we need support. We need people that have our back. We need providers that can lead us in the right direction or diagnose us even, or just give us help. And we also need those tools, whether from others, whether we find them within ourselves or online or wherever it be, but something to get us through these difficulties. And I say this to say that, no matter how long your journey is, no matter what's happened, or whether we're still going downhill right now, or we're stuck at a plateau, or maybe slowly changing, there's always this opportunity that things can still change for the better. And that doesn't mean that it's all going to be symptoms. It might not all be functioning, but there's still ways to make this life better. And my charge to you is going to be to find things that still make this life something valuable, something that's still fulfilling, and finding ways to keep moving forward, even when things get difficult. So I thank y'all for listening and working with some of my technical problems that happened today. And I'll open it up for questions. Thanks.
Thank you, Dr. Frye. That was a very informative and helpful presentation. So thank you.
Okay, let me see what we have. Okay. So the first question is, in dealing with dysautonomia and comorbidities, how can I mitigate against potential barriers to care, and what steps can I take to alleviate a siloed healthcare system and allow a more collaborative clinician environment? For example, urology mentioned to me, what does urology have to do with cardiology? And this made me feel like I'm not being seen or validated. Another example is team members looking at their watches when I had taken time before a procedure to list my concerns.
Oh, all right. I'm looking at this one too, because that's a long one.
Yeah, I kind of trimmed it down a little bit.
Yeah. Goodness. Talk about a very relevant problem though. For many people, this is going to be siloed. You're going to see one provider that doesn't talk to this provider, that doesn't talk to that provider. And we know that dysautonomia, it's a multifactorial condition. It affects all these different systems within your body, and especially a provider that doesn't really understand. Well, they're going to say, why are you seeing me? I think first, whichever provider refers you, having a good 1 to 2 sentence summary to say, hey, my cardiologist, they referred me to you because they are worried about this and this. And so then the urologist can say, oh, okay, that's what we're looking for. And it might be that it isn't something that they focus on. And they might do their tests, it's all clear, and they say, hey, this isn't me, I can't help you much. And maybe that's what cardiology needed. Maybe that's what the first provider was like, yeah, I just want them to check off, no big deal, I still have your care. I think the big thing is having one person, like, not saying you should only have one provider, but one main person that really guides you for which specialist do I go to and can be your home base. I think that's going to be something that's going to mitigate a little bit of the problems because you have that one person. I think too, along with a little summary, is just being able to discuss what the concerns are very specific to that person. With dysautonomia, you got there are a few conditions in here. There's so many different symptoms that some providers, they get overloaded, they get overwhelmed, and they say, oh no, this isn't me, you got way too much. And sometimes it's just whittling it down so it fits in what they understand. Now, is that the best? No. Should they probably be able to address the whole thing? Yes. But realistically, and unfortunately, that doesn't happen with all the providers. So I think that's important. The other thing too, I mean, providers looking at their watch, people that are being rude or condescending and things like that, that stinks. I mean, I think ideally I'd say, yeah, you go find another provider because obviously they're not the right one. You might be stuck with this person though. And in the cases where you are stuck, I think being able, again, to connect with them on a level that says, hey, here's how this is affecting me. Here's how it's affecting me in your domain. And, here's what it is. Although, it stinks. You take time to come to a visit, you wait in the waiting room, you want to talk to this provider and they're blowing you off. Yeah, my first thought is, how do we get somebody better for you? Again, that can be tough to find.
Dr. Fry, would you suggest that that person say to the provider, you know, when I was with you last time, when I was trying to explain my concerns, you were really not not paying attention or seemed to be preoccupied, and it made me feel this way, so that they can have an open dialogue and the patient may then feel better? Or should they just know, okay, this is the way this doctor is, and I need to either find somebody that I'm better suited for, or if I can't because they happen to be the only one in town, I need
Uh-huh.
to just accept this? What would you
Oh,
recommend? I know it's a tough one.
personal preference. Because here's the thing. I think, Cindy, what you just described is what should happen. To be able to say it in a nice way, hey, here's what I noticed. I don't know what's going on. Let's talk about it. And then they talk to you about it. You come together. They listen to you better. That sounds beautiful. Unfortunately, we're not all comfortable with that.
Yeah,
Sometimes our emotions get the best of us when we try to have this conversation, or even more so, the emotions get the best of the provider because they feel offended, or you attacked me, or they get really defensive. And so sometimes that conversation never builds.
right.
Feel comfortable with it, I would absolutely recommend having an open and honest conversation about here's how I felt. But I then have to wonder, well, why did they do this in the first place? Maybe they have a certain feeling about this condition, and that's leading to some of the other things. Another provider might be the best, but if you're stuck with them, you really have the option of, do I have this open conversation or do I ignore it? With either one, there's risks. Yeah, the more I talk about this, the more I think have the open conversation, but just know you may not get everything you want out of it, unfortunately. Um, but yeah, I think if you can describe what you saw and what you want them to understand, for some people, it might open them up.
Okay, great. Thank you. And I wanted to make a comment too on the provider, like asking, like, why are you here to see me? It's very easy when you're so sick and you have so many symptoms to want to go in and almost, you know, dump everything on a provider. And one of the things that Dr. Trevino taught us is top three things, three symptoms, like you say, come in there with a sentence or two of, this is why I'm here to see you, and these are my top three symptoms. You know, I'm lucky that I have found a lot of specialists who are interested in what you're doing or other doctors are doing, but you aren't always that lucky. So, you know, if you could try to limit the number of things, I think you may get a better response from that particular provider. So, okay, Morgan.
Okay, so next question. Is there a particular type of therapy that you recommend, like CBD? What are your opinions on TMS therapy for depression?
All right. So now I'm a pediatric psychologist. I should mention that first. So I absolutely don't recommend THC or CBD for any of my patients. When you start getting more in the adult world, there's some people will say there's potential medicinal benefits, especially for pain, mood, things like that. There's not much research to back that up. That CBD versus placebo, there's not much difference, if any. For dysautonomia, I don't know of any research that would suggest that there's any benefit of using CBD. For mood, same thing. There's no evidence that there's any benefit for it. THC, there's actually evidence that it could make it worse because a lot of people use it as a tool for avoidance, much like drinking. So there's that. Now I know some people use it and some people find benefit. You got to balance it. As for the TMS, the oh gosh, trans stimulation, electrical stimulation brain. I'm can't think. Yeah, for that, if somebody has a real intractable depression, it's depression that we've tried everything and it's not working, it's very severe, a lot of suicidality. Some people will still recommend that. Pediatrics, I don't recommend it. I think that you just gotta again see what all's out there. The gold standard for any type of depression is going to be starting with behavioral activation, just doing stuff, getting life moving, even if not the enjoyment, but just getting in the cycle. And then therapy, usually cognitive behavioral therapy is the one that's most studied and has the most evidence. There's a few other therapies too. I mean, really just getting therapy and working through some of those thought patterns that lead to the depression. also medication would be one of the other ones. So, for some people, they use it. I've had patients that have used TMS before, adult patients that are about 18, 19. Some have said, hey, it helps some, but I'm still depressed. Other ones have said, yeah, it was good. Some it didn't do anything. I don't know if it would, again, it wouldn't be my first recommendation for anybody, but hey, if you're trying things and it's something that you might think you could benefit from, I'm not going to say don't. So that's, again, more personal, but something to look into if that's something you're already interested in or thinking about.
Thank you. Here's a anonymous question. What do you think about ketamine for pain and depression? And I was kind of wondering the same thing after the TMS.
Yeah, there's real mixed results. Ketamine, especially in adults, there's more research coming out for its potential role in depression. I actually saw something the other day about it. There's something else about microdosing, not LSD, but any of these mind-altering things that could potentially have a benefit. Very young research, though. Ketamine has a lot of what do you call it? Side effects. It can do a lot to the GI system, and there's some other things that come with it too. Doesn't work for everybody. Can be quite costly. Not often covered by insurance. All things we gotta consider. In my anecdotal experience from both people I know in life and from kids, I've never seen anybody get better from depression with ketamine. I've seen them get better for a minute, but nothing long term, because depression is a thought disorder. I mean, that's what we're working with. There's changes that happen in the body and the brain, but the essence of depression, the way it's described, is a disorder of thoughts. So ketamine's only going to be, it kind of be like any other medication you might take. It's going to be something that might help, but again, especially for ketamine, how long is it going to last? For pain, it depends what's going on. For chronic pain, sometimes people will use ketamine as part of the treatment, or especially for acute pain, it can be used. It's not something I'm big on. I think it's misused in a lot of situations. But yeah, it's something that you'd want to talk to your providers about, depending on what you're experiencing and what options you've tried. Um, I think my big concern with ketamine, especially in Florida, there's a lot of ketamine mills where people just want you to come in and take ketamine, and they'll tell you it's good for everything, and you pay them several $1,000s, and then the next year you're nowhere different, maybe about the same. And that's what I worry about for patients, that when we're feeling depressed, when we have pain, when we have symptoms, we're more vulnerable because we'll do anything to get out of that. So that'd be, again, my personal thought, but something to definitely check in with your providers to see what their recommendations might be.
Okay. What changed your mind about dysautonomia from where you first were training to now doing research?
Y'all talking to me. It was the patients. That's who changed it. I mean, uh, I think there are a couple stories I heard. One from a young lady that lived down here who took her own life just when the symptoms of dysautonomia got too bad. And one of her friends from high school was one of my friends. I'm a runner, or used to be a big runner. And so there was a 5K in her honor. And I'm like, oh, I'll do that. And then I learned about it a little bit. And I'm like, oh, that's interesting. But then after getting to talk to her mom, after starting to meet other patients with dysautonomia or POTS, and then especially when working with them, learning more about their story, and like, wait a second, these kids aren't losers. Like, wait a second, this kid isn't some feeble-minded person. This isn't some weak kid. This is somebody who has some real stuff happening. They don't like it. They want to get better and they can't, and no one's listening to them. And I'm like, we got to do something about this. Which probably all of you were like, yeah, duh. Unfortunately, I was a little bit slow on that one. And I think it was just having those experiences with patients, and patients just explaining what's happening inside them. Again, they didn't tell me, oh, I'm feeling tachycardic. I'm like you might as a doctor. I'm a psychologist. They're telling me more of this impact on life, or really expressing some of the emotion behind it. And slowly but surely, the light comes on, and you're like, oh yeah, like this isn't any of this stuff that I was initially taught, which is cool because now I get to train a whole new set of psychologists and even some medical students that are going to know better. Unfortunately, though, I mean, I'm talking about training that occurred in 2017. So it's not like this is something that's, again, archaic. These are still things that people are being taught. But yeah, it was you all. It was you talking to your providers, sharing that information. That's what changed things.
Thank you for listening.
thanks for talking. I mean, but think about it. You go to a provider, you've probably been invalidated before. You have people that don't believe. You have people that don't understand. You may have never heard of dysautonomia, and somebody says, "Hey, you're crazy. Here's some Prozac." I mean, that's the experience of some people. And then
Yes,
you go to another provider. Why would you want to say that same thing and get invalidated the same? Like that stinks.
yes.
And so it's so hard to talk about. It's so hard to be able to express what you're feeling and the emotion behind it because people might label you as just an anxious person, and here's why you have your symptoms.
Yes.
It's incredibly difficult to have these conversations and to talk about it. So I think yeah, it's a two-way street. Yeah, the doctor's got to listen, but also to be able to do it in a way that they can hear you. Um, and it's going to depend on the person. I mean, there's some people that are going to be stuck in their ways, but that's becoming fewer and fewer.
Right.
Okay. Any other questions? Feel free to either unmute yourself to ask, or you can put it in the chat box.
Yeah. I saw a positive note on here about people talking about keeping forging on and how long it can take. And it is not a diagnosis of exclusion. That is correct.
Yeah.
There's actually, this is medical. We can see it. We can test it. We can feel it,
Yeah.
which is cool. And then having practitioners that can help assess this or treat this is really important too. Again, depends on where you're at. There's some people, your country may not have access to it. Your area might not have access to it. I know where I grew up in the Appalachians, there definitely isn't anybody that does dysautonomia, at least that I know of. Hope there is one day. But so there could be that you have to travel, or it could be that you're getting a lot of information from groups like this and being involved in it and having people that have had success and even you sharing your success, I think is incredibly beneficial because the big picture for me is to have people see that there can be a light at this tunnel. Who knows what it looks like? Isn't going to look the same as you were, but that's okay. We're something that's ever changing and, hopefully working towards getting better. Oh, and they do virtual appointments, even better. So
Yeah.
you might be able to do it from afar.
Definitely. Dr. Fry, I've had a 50-year journey with autonomic dysfunction. And so in my past medical records, they had put depression and anxiety, which of
Mhm.
course it was neither of those. Is it important and can we even get that wiped from our medical records, or does it just not really matter?
It depends. Yeah, if I'm looking at a medical record and there's things from other people's notes, previous assessment, et cetera, especially if it's in the same system or same medical record system, um, I'll see that and it'll come up. In fact, when I'm looking through medical records, I'll search keywords I'm looking for. I'm a psychologist, so I'm going to look for any history with psychology or anxiety or depression before I see a patient. It's helpful. What I would recommend if you're not experiencing it, and by the way, you can have both. A lot of people have both. You have depression because you have these symptoms, or maybe you were already depressed and this really put it to another level. That's okay. But I know why people would be to have a little angst about that because you have been invalidated about this. If it's the case where it's, hey, I have this, but I'm not anxious anymore, that wasn't accurate, you can tell the provider, hey, I've been labeled with anxiety in the past. All that's resolved. I no longer, meet that criteria. That's the wording I would use with to somebody if I was talking about it. It's really because in most of these medical records, they can say, is it active or is it resolved? And so it's this history of it or previous diagnosis, or even to mention, hey, I got diagnosed by my MD one time. They said I had this. They didn't really test me for it or do any assessment. And, looking back at it, it's something that's resolved. I'm feeling a little bit different now. Any of that type of information is good. Although you can sometimes request, hey, can you remove this diagnosis? Some providers will, some providers won't, depending on how they personally feel about it.
Okay.
But yeah, addressing it to them directly is the best way.
Okay, great. I'd like to reiterate on some of what you were talking about as far as chronic illness is hard, and it's very easy to get depressed and to focus on your illness, particularly if you're bedridden and every day you wake up feeling like you have the flu. It's hard, but Morgan and I are both walking examples that you can go into remission with this, and you can change your focus to your life isn't autonomic dysfunction anymore. Autonomic dysfunction is a part of our lives. And, learning coping techniques, finding support groups, finding like-minded people to be able to share with what, you're going through, can really make a big difference. For myself and Morgan, running these groups, working with you, doing everything we can to help support those people that don't have doctors that believe them, and family and friends. And so I'm glad you did that. Focus is that, we need to make autonomic dysfunction a part of our life, not our focus. Because if you don't have hobbies, and guys, hobbies can be playing Go Monopoly on your phone, I mean, seriously, it could be something as simple as that, coloring. I went through a period where I did adult coloring, and it just takes your mind off of it for an hour. That's a successful hour when you suffer from chronic health issues. So I really appreciate you hitting that, and discussing that, we can be more. We can be more, and it just takes time. And it takes, for me and for Morgan both, I know I can speak for her, it took us working with our doctor, um, trying this medicine, trying compression garments, trying, okay, how many bags of fluid do we need to run by IV? It was a try this, try that. But, successfully, after 3 or 4 years of that, I started to get back on my feet. And now I'm able to babysit my grandchildren, and, do a little bit of side work. And Morgan, I'll let you speak to, some of the things you went through. But staying positive and being around like-minded people and finding those doctors. And I'm glad you mentioned, if your doctor isn't providing you quality, fire them. We interview the doctors as much as they, interview us, and determine if they want to treat us. So thank you for sharing that as a doctor, to share that. Like you said, be kind, guys. But, if you're not getting what you need, then it's okay. It's okay to say, I need to get another doctor. Morgan, do you have anything you want to share?
I feel like you summed it up pretty well. I just remember, I mean, I got sick as a teenager. I was 14, 15, like peak high school years. And I remember my mom. So my mom was an RN, and she would always tell me, oh, just be positive. Like, it's going to be okay. And I remember being a teenager, and I was just bitter. I was like self-isolating. I'm like, you don't know what it's like to be sick as a teenager. You had your teenage years. And it was like the year before, I was traveling on summer vacation, and now I can barely roll to the other side of my bed. And it's like self-isolating. It's easy to feel like you're at the bottom of the well, and everybody else is like, oh no, just be positive and you'll be fine. But it's like, now from the outside looking in, it's like, I wish I knew in that moment that like it's true. Like it can get better, and it's not, you're not just going to wake up one day and have it happen. It's something you have to work towards. And whether it's small things like playing Monopoly on your phone, like Cindy said, or reaching out to friends, like I self-isolated because I thought they didn't want to deal with me. But in reality, they were reaching out, and I was choosing, like, I was bitter. Like, you guys can go do whatever you want, and I can't. Like, why would you want me in your friend group? And I think it's just important to keep your people around you and find people you can lean on, whether it's other patients going through the same thing, or it's like friends or family. Like, just don't isolate yourself. It's really easy to do.
Yeah. And social media, it can be a curse, because, here you are laying in bed, and all your friends are, going kayaking and going to the mountains hiking, and, all these things that you used to do and now you can't do. So, okay. All right. Well, Dr. Frye, thank you so, so much. This has been recorded, so we'll get it edited and posted up on YouTube. I'll send you the link. We so appreciate you taking your time and doing this for patients worldwide to be able to benefit. And, just thank you from the bottom of my heart.
Glad to be here.
Yeah. All right. Thanks, everybody. Have a great day.